the chairman are Georg Gaul and Flavio Ribicchini. We have in panel Bela Merkel is not present now, Georgi Szabo, Maciej Lesiak, Petros Dardas, and Jorge Palazuelos. We will, Georg, I could propose we will start with presentation of the case because the cat lab is waiting and is ready. Wojtek, Michał.
So, okay, then we continue with my presentation of the case. Yeah.
Yes, I would like to present the case. So, our last patient is a 72 years old man with a stable CCS2 angina. He underwent 2 myocardial infarction in the past years and quite recently TIA. He has a borderline ejection fraction and chronic kidney disease on chemodialysis, also type 2 diabetes mellitus. He underwent diagnostic coronary angiography with recessive right coronary artery and diffuse disease in the left coronary artery. After this coronary angiography, the patient was consulted during our heart team meeting and was disqualified from surgery, and now he's awaiting his first procedure. Thank you.
What is planned? Do you know what is planned as a procedure?
The ostial LAD seems to be the target.
LAD 3 times as far as I remember, and I've seen 3 lesions in LAD. So we have whole spectrum of rotablation indications. Our first live case, it was undilatable lesion. Our second case, it was uncrossable lesion, and now we have a primary indication based on the heavily calcified, not only lesion, but heavily calcified whole LAD, heavily calcified artery.
And you will leave the circumflex with this subtotal lesion completely?
Decision depends on operators.
Up to, yeah.
Hi. So welcome from the cath lab here in... okay, this is camera. So welcome from cath lab here, and with me is Maciek Telichowski. So we perform many cases together, so we are experienced team, and we plan to do a long LAD rotablation. It's a long lesion of calcified LAD, and we plan to do this using femoral approach. 7 French. Patient is on hemodialysis, so it's clear we should go using femoral approach. And we plan to perform primary rotablation, so without trying to go with a balloon, not to risk anything, just go with Rota 1.5 burr, and then we will see. This is a case which could end with left main stenting because it's ostial LAD lesion. So I suppose we will have to stent from left main to LAD, and then 1 stent more to the mid part of the LAD. I don't know, did you see the case presentation?
Yes, we did.
Okay, so can you see now the angio?
Now we see angio.
You see the patient's hand, so one more shot to understand better the anatomy. So Maciek is doing this. So you see it's a long, large vessel, very long lesion, diffuse, so there is practically no area, no segment which can be defined as healthy segment. So everywhere are many plugs, but I think the most
So Mirek, what are
problematic
you planning?
part is here in proximal. There is some eccentric plug, which can be seen, maybe, no, it's here, probably you see here. It's a very calcified lesion, hazy, so we plan to go with 1.5 to the mid part of the LAD, and then maybe to perform more debulking using 1.75 for proximal lesion.
And could you explain us why you are starting with a 1.5 millimeter burr and not with a smaller one?
The vessel is large, and we don't want to go to the very distal part of the LAD. Initially, my first intention was to take 1.25, but we don't plan to go through complete LAD. So we just fix the proximal part. There is an ostial proximal stenosis. There is one stenosis more, subtotal. If you can see, there is a first septal branch. There is a bigger problem. And then finally, if you see a bit more distally, there is one more septal branch. And we will fix exactly 8 millimeters behind. We will stop there. So we don't go more distally, so that's why.
But in the other projection, this mid-LAD stenosis looked quite tight. So I would be concerned that it is perhaps a too big burr in this situation.
I think it's still okay. So I would just go now with 1.5. We go now live, so we didn't cross the lesion. What I have is here fine cross, fine cross, and we go now with samurai wire, which I like it, and use in daily routine in our cath lab in Bad Krozingen, Czech.
Why do you like so much samurai wire, Mirek?
Look at here. I like sushi and like samurai.
Do you like sushi?
I like sushi, yeah. So it's going very nicely. Check. So we are now, you see, we spend just a few seconds to go to, but I don't, we have patients, it's not really slim, so that's a small problem here. So now it's probably better. So you see, after 15 seconds, we are now in place with fine cross. Go now with rota wire. Can I have it, please? Go with access support rota wire, and it takes now some additional 10-15 seconds, and then we can go with rota.
Mirosek, did you consider to advance directly the rota wire instead of the catheter?
Not really. So I think it's, in our institution at least, practically standard to use micro and then to go to use micro as the first part of the procedure. We go with floppy wire and then micro and then exchange to the rota wire. Okay. It's safe, 100% safe, 100% safety, very easy, fast, and we don't produce dissections.
Yeah, but it's expensive. Maybe you can try in these that are not critical lessons.
Yeah, okay. That's correct. We saw yesterday a few cases from Dr. Dobrzycki, so he practically always try with to go with primary to go with rota wire. We do this in our center, of course, but if we have long lesion, many plaques, I think it's safer and faster. Could you open the flashing? Flashing is coming.
Many of my colleagues use originally the microcatheter to advance the wire.
Could you show us in a close-up how you advance the rotabur on the wire?
Yeah. So we let it here drop. Its fluid is, saline is dropping of the wire. Wire is wet and is going very easy forward. Okay, now we test the speed.
Anizo. Obroty.
We have dyna, so now we go to 165. So we use 165. Okay, perfect. Yeah, so fine. And we go now without dyna, as long as is easy going. And then maybe the last part, then we use dyna. There is some resistance. Okay, so we are in the left main in front of LED. So before we start and make first shot, so we give atropine, 1 milligram atropine, and we relax the system.
Excuse me, maybe you can explain to the audience the tip and trick we have used placing the
Proszę
brake.
zabrać prawą rękę za głowę.
You know?
What do you mean?
You use the torque and put it inside the brake for advance the advancer and the bar with the glide. Your colleague show it.
Yeah, that's a fine trick. It's working very easy, so you don't have to take care what wire is doing. Just if you have 2 doctors at the table, so it's not really necessary. But if you're working alone, it's very helpful.
Now you're switching to high speed?
Yes, we just first step was on dyna just to relax the system, and now I'm going to the high speed. Okay, it's hard lesion, so we go back after 8-10 seconds and go forward again. You heard what Dr. Gaul is always telling, the voice is changing, the sound is changing, so then it's time to go back. It's hard. So we check the flow, patient is stable, ECG is okay. No, still very hard. Patient is very, I think, very important topic just to take time. Patient is fine, stable, good pressure, so we go again after a few seconds. So it was easier now to cross the mid part. There is one more option to go to the third septal branch, and then we stop it. I think there will be our landing zone, and then we go back, take a look, take a shot, and probably go then with 2.5 non-compliant balloon. So this part is okay. So check the flow. So it's not bad. I think we crossed. So we go now back. So Maciek is going back on Dyna. Are you ready? You tell me. I think important to take care where the wire is and guiding. So very good. Okay, fine, perfect. So we still let the rotor wire in position, make now some shot. Pressure is stable, ECG is okay. Patience, jak się pan czuje? Wszystko okay? Okay. The patience is fine. So just take a look how it looks. So the flow is okay. You see we were, with the bulking, we were not perfect in the proximal and ostial LAD. And for the mid part, I think it's okay. The question will be now for discussion to go with 1.75 burr or just to try now with 2.5 non-compliant balloons and just take a look how it looks. If balloon is well expanding, then I think we can go with the stenting. If not, we can still discuss rotablation using bigger burr. What do you think? Do you agree with this approach or?
Mirek, I think the goal was to break the calcium, not to debulk, yeah, because I think the bifurcation is not endangered, the circ so should be okay. So I wouldn't go for the bigger burr because the majority of cases 1.5 is quite enough.
Balloon. Yeah, okay.
Pipe 2.520.
So we
take a little bigger balloon than 2.5 to
or
open.
maybe a cutting balloon.
2.520.
3.6.
2.5. So we take now 2.520 quantum. We will see. We start in mid part of the LAD very gently, and I suppose it should work. And for proximal part, we take a minimum 3.0, maybe 3.5, and see balloon. Okay, just so we still let rotor wire in position just in case we need additional rotablation. But then we can exchange very easy to floppy wire, which is on the table. So you see very easy crossing with balloon. It's no problem. Just maybe Maciek is just checking. I think that's perfect. We go now with 10, 14 atmospheres. So balloon is well open, very nice. We go a bit back. One more. Okay, negative. Okay, again, 16, 18.
In these cases, it's sometimes very, very helpful when you have long balloons on shelf.
Yeah, you're right. We should take, normally we should take now 30 or 40, yeah. Okay, but Magic is fast. Very fast. He is top guy. Okay, now we go with 20. Yeah, it's not bad. So we are now more proximal. So I check this here to see how. Check. Okay, so we still have some room, space to the left man. Okay, and maybe we can just avoid left man standing. Will be not bad because there is some mismatch in diameter between huge left main and LAD LAD. So I would definitely take 3.0 non-compliant balloon 20 3020 3020. Okay, so we take quantum again, but larger balloon for the proximal part, and then I believe we can go with long synergy. Do you have 48 millimeters here?
Stand?
Mm-hmm. So we need now 3.0. Come. So just predilate better proximally. The proximal segment is still not perfect.
Musi leżeć. Nie ma wyboru. 32 najdłuższe mamy. Synergy 3,540 mamy 32.
Okay. So we go now, I don't know, here's like spider view, not good to see. I'm just going a bit back with weight. Check. Okay.
16.
No, 20. Negative. So test. I think balloon was moving forward. I have impression.
Okay.
Check. Test. Yeah, a bit back. Niech pan leży spokojnie. Don't move. Check. Okay, one more. Okay, 20, 22. Okay, negative. So we do now again short movie. So there is still eccentric stenosis and a lot of, you can see over the open area, there is still a lot of material which can cause maybe problems after stenting with probably heavy recoil.
I think the first branch included this why the rubber band stopped.
So we need now long stand.
Reclassification and
Proszę pana, niech się pan nie rusza.
There are two suggestions from the panelists.
Yeah.
One is cutting balloon and the other is IVUS.
I think cutting balloon is very close to the left main. We'll be a bit skeptic, to be honest. So we
still see, you know, the denting in the proximal ostial LAD.
Yeah,
so
there is a lot of material, and that's why
region. So you have to either go with bigger balloon, high pressure NC, or cutting balloon, or just check
definitely. But first, we can go now with a first long stand to the mid part of the LAD, and then on the way back, definitely we will use 3.5 short non-compliant balloon with higher pressure, and then we will see. But then before we do this, we put wire to the circ just to protect the circ, because if you have retrograde dissection of to the left main, so you could have big problems, left dominance here. So can we have now longest to 3.0? Longest 3.0 synergy. And somebody could bring 3.58 millimeters
3.58 millimeters
balloon.
3,5-8 NC.
Quantum.
Tak.
Quantum. No.
To też.
Yeah, open. So we go first with stand to the mid part LAD.
Ten.
Yeah, open.
Otwieramy. Pani Izo.
Okay, so we go now with stand. It's synergy 3.038. So I don't expect any problems with crossing to the mid part of the LAD. But for the proximal part, we need definitely better lesion preparation. And for this situation, we have practically only two options. One is to use non-compliant balloon with higher pressure, then to use 24, 26 atmospheres, or to use OPN balloon will be one additional option, or even to use cutting balloon. Fix. So we go now with synergy. So synergy was crossing very easy. So it's really low profile stand. Go check. So what do you think? I think it's not bad. Movie, go. Yeah, maybe forward. We need to go a bit more forward. Too much. So one more movie. At ACT, we test ACT.
Ready?
So this is for me and for Maciek exactly the landing zone. So we go now with 2, 4, 6 gently. Gently, not too fast.
6.
Can I have water here?
8.
This was also the region where we almost heard this high-pitched sound of the rotablation.
Yeah, you're right. 12. So, but you see, I think stand is well expanded. So what is really very important message to younger doctors, so just let balloon in position and make safety check, because if we have perforation, so we could just open balloon again and avoid tamponade. So very good option is just to go back with a balloon and test the length for the next stand. So we can use this. So we need probably 48, or we need one stand. Okay, check again. Check again. So definitely we would like to have now synergy 3.538, okay? Okay, and that's the time now to go with one more wire to the circ. Bye-bye. So could I have samurai? So, what do you have?
We need two stands.
That's okay.
Mirek, could you explain us the stenting delivery? To which pressure do you inflate the stent?
So we implanted now the first stent with 12 atmospheres. So we don't go to higher pressure. We just implant the stent, and finally we perform for 100% of cases, we perform post-dilatation with non-compliant balloon. So just open the stent, and on the as a final step, we definitely will perform post-dilatation with 3.0, then 3.5, and 4.0 non-compliant balloon. This is, I think, a very important topic.
And why don't you leave the balloon there, and when you have no dissection or perforation, inflate it again with 18 or 20 atmospheres?
It's not enough. So there is some data, even from Japanese doctors, they could show that you need definitely non-compliant balloon to avoid partially malapposition of the stent. This is what we do in daily routine. So, to be honest, I perform in 100% of stenting post-dilatation with non-compliant balloons. So this is standard. Just to be we don't do in every case IVUS for that, but we know if we go with post-dilatation with non-compliant balloons, then we are on the safer way. So now we just go with a 3.5, 32 millimeters. It's synergy test. So it's, I think we have overlap for 1.5 millimeters. So do you have here?
No, we haven't.
You don't have it. So we could. Okay, just go. So Maciek is going now very gently. 2, 4, 6. Don't. Niech się pan nie rusza, proszę. Don't move. 2, 4, 6, 8, 10, 12, 14 atmospheres. So we stop. Negative. We let balloon in position. It takes a bit time. For I need this wire. And just make again small injection to see if we have flow and there is no perforation. So now we go back, and for next step we will use 3.5 short non-compliant balloon. So we have on the table quantum or 8 millimeters, 3.5 high. It's
maybe you can see from there better than us, but it seems that it's have a gap between the stents. Is it possible when the patient have?
We will see again, but he was a bit moving during this procedure, so that's why maybe we lose its position, but we check this. That's a good point. It's happened sometimes, yeah. And stand boost will be very, very helpful here in this situation, because it's not easy to see if you have, if you take synergy or integrity, you don't see so perfectly.
Maybe movie without contrast.
Yeah. So I would suggest at the moment it looks not bad. We do one more projection from the epicaudal view. So for now, we go now. So we go for now with next wire to the circ, because now we're very ostially to the LAD and left main. So if we use high pressure balloon, I don't know who of you saw retrograde left main dissection, so it could be very difficult to manage this. That's why, for safety reasons, I put one samurai now to the circ, and then we go with 3.58 millimeters to the ostial LAD and use pressure up to 26 atmospheres. Check. So we just test. You see the circ is Can I have talker? There's side branch and I would just go really very distant.
I have a proposal, Mirek,
yeah.
Georg, because we are behind the schedule and have still 3 cases to present.
Okay, we
just leave you with the circ, you will work, and then you will show us the final result.
Yeah, that's a good idea. We just go. We need a few minutes still. Okay, balloon. Okay, we are back. Hello?
Yes, we can hear you.
Okay. Yeah, we had, after simultaneous, I would say 4 or 5 times predilatation of the ostial LAD lesion, a patient was suddenly hemodynamic, unstable according to the rhythm, so he developed ventricular tachycardia, so it was necessary to perform resuscitation, defibrillation finally, and now he's intubated and at the moment at least stable. And the main problem was that multiple predilatation with big balloon provoke, I think, prolonged ischemia, and over this mechanism he went to the unstable rhythm, and then of course pressure was down, and that's why we had some stress now. What we have done in this acute situation, we put it very fast stand from the left main. We can maybe go back. So it was postulatation. After this postulatation, we put it 4.0 postulatation proximal.
Mirek, wait a minute. Could you come back to the moment it happened? Was it directly after dilatation? Was it any dissection or flow disturbance?
There was no flow, probably because of distal embolization It's probably it was the main mechanism for no flow. And so what we have done then, very fast stenting from the left main to proximal LAD with 4.0, I believe it was 4.028. And already we were lucky to have wire in the circ. So then at least this was safe. And after post-dilatation pod, rewiring, then kissing. So this is post-dilatation, pod. Now kiss, can you see this?
Yeah, we can see.
Yes,
yeah.
we can see.
Then kissing, and this is practically our final result. So we have some slow flow in the LAD area. So it looks like this. So there's flow, maybe TIMI2 in distal LAD. There is we didn't touch circ distally, and we didn't touch this marginal branch. I think patient is now stable, so we would suggest after final report we will leave this case.
Is the patient on inotropes?
Yes. Yes, but only minimal dose now, so it's not a big issue. But I was surprised, even this multiple post-predilatation were responsible for ischemia induced tachycardia.
You have shown that ballooning may be dangerous, not rotablation.
Yeah, but of course it was a problem. But could you imagine if we make maybe perforation in this proximal LAD, so patient will
Have you
die.
checked LV function in ultrasound?
Not yet, but it's the next step. Yeah. So the question is, so we restore the flow in the LAD, circ is dorsally open, and circ marginal branch is practically occluded. But the question is to go forward with PCI, to open this side branch and to treat distal circ, which is not critical, or just to leave it for stabilization of the patient.
Leave it alone, in my opinion, leave it alone.
Yeah,
of course,
me
not,
too, yeah.
not in this session.
Yeah. He is stable now, so we have now pressure around 100, and I think he is intubated, sedation, you know. So I think for the first moment, I think it's clever and wise to say, okay, we stop here. LAD is opened. It was our primary goal, and he needs now good care at ICU.
One has the impression that there is between the proximal part of the LAD and the long mid LAD stent that there is some lesion still, but I agree with Krzysztof not to do anything now and wait for the development of the patient.
Yeah, I do one more projection here, so we can see now maybe better LAD. You can just go back. So I think you see there's really diffused damage, diseased LAD. Even distally there's some stenosis. So, but for now, I would suggest to stop here and.
And the blood pressure was falling gradually or suddenly?
The problem was tachycardia. You know, according to the tachycardia, it was acute problem. Okay, so I think this can sometimes happen even during tough case. The flow is restored, and I believe the patients will recover at ACU.
We hope as well. So thank you, Mirek and Maciek.
Okay, thank you. Bye bye.
Thank you.
Okay.